In the field of MPN, there was really no agents about 10 years ago that were targeted and specific. And then you have Dr. Verstovsek and team pioneering the ruxolitinib agent, and now the newer one, fedratinib. But those are all in the same category. That's JAK inhibitor. Not every patient will respond to a JAK inhibitor. Not every patient can get one if your platelets are below a certain level, or if you're intolerant because of side effects, or the disease figures out a chance or a way to resist or progress. So JAK inhibitors don't appear to be a cure in and of themselves. Allogeneic stem cell transplant appears to be the only cure still. So you don't have a curative therapy, but you have one that helps the quality of life, can decrease the spleen, and can improve the overall survival in many patients. So the concept here is, can you add another class of drugs to improve on the clinical efficacy, keep the safety very good for the patients, and then of course going for things like long-term survival, long-term cure, maybe even not need to go for a stem cell transplant. Those are the investigational concepts. So I think you're right. I think the question is the why and how do we need and how do we use these new drugs? It's to improve, but maybe even to go for things like cure. We're not there yet, but why not dream big and try to go for that? And also combination therapy is already being used in all the other leukemia fields, both acute and chronic. So CLL, there's starting to be trials even in CML with combination study. Of course, in the acute leukemias, they've already been doing that for decades. So I think the time has come to at least investigate these options. But I want to emphasize, only on clinical trials, only at centers that offer that. These are not FDA approved, right? So it's important for people to know that these are in controlled clinical trials with PIs, principal investigators, and clinical trial teams.